Hi, my name is Jorge Castillo, and I'm the director of the Waldenstrom's program at the Dana-Farber Cancer Institute. Today, we're going to be talking about current treatment options for patients with Waldenstrom's macroglobulinemia. Waldenstrom's macroglobulinemia is a very interesting condition and has multiple ways in which it can affect patients. We do have in this graph, as you can see, multiple ways in which this disease can affect patients. Some patients can be asymptomatic from Waldenstrom's, but some patients can have symptoms, and the symptoms can be related to a variety of conditions, including anemia, including hyperviscosity, neuropathy. Very rarely we can see pleural effusions, even some renal involvement, and the very rare meningitis because of Waldenstrom's called Bing-Neal syndrome. It's interesting to see that this condition has so many different clinical features, but at the end, they all fall into this category of being Waldenstrom's macroglobulinemia. Now, despite the fact that we have so many symptoms, we don't have to treat everybody at the moment the disease is diagnosed. And there are several reasons for it. First and most, Waldenstrom's remains an incurable condition. Despite most of the advances that we have had in terms of treatments, we cannot cure Waldenstrom's as of today. Obviously, a lot of research is being done to try to get to a cure for Waldenstrom's. So a treatment to cure is not an objective of our treatments currently. Now, our treatments, although they are very effective, they do have some downsides, and they do come with toxicity, right? We do have neuropathy, secondary cancers, arrhythmias, and we'll talk about that a little bit later. But they also promote resistance. Every time we treat somebody, we don't cure the disease. When the disease relapses, it will be just a little bit tougher to treat the second time around. We don't have any evidence that actually treating patients early in the disease process, it prolongs the survival of these patients either. So treating to prolong survival is not something that we routinely go for in patients with Waldenstrom's either. In patients with Waldenstrom's, as you know, enjoy decades of life in terms of survival, and a large proportion of our patients do end up having a normal life expectancy, as most Americans. So for all those reasons, if a patient is asymptomatic or minimally symptomatic, we should consider observing rather than intervening. Now, if a patient does get to a point in which some of these symptoms appear, including a hemoglobin less than 10 grams per deciliter, or symptomatic hyperviscosity, or progressive neuropathy, or some other manifestations of the disease that are symptomatic, that is the time in which we need to start thinking about potential treatment options. So when we think about treatment options in patients with Waldenstrom's, we do have a number of treatment options available, and all of them are very effective, but they all have their own specific profile in terms of adverse events and also how it's administered in the duration of the study. So we'll talk about these features of these treatment options down the road, and in that way we can personalize our approaches more appropriately. Let's start with reviewing chemoimmunotherapy. Chemotherapy agents we fall into two big categories in terms of Waldenström treatments. One of them is nucleoside analogs, and the other one is the alkylating agents. The nucleoside analogs, fludarabine and cladribine, have been around for a while, very effective in patients with Waldenstrom's, and actually probably some of you have been treated with those agents. However, there is a high risk of myeloid neoplasms with that, and some degree of stem cell toxicity as well. So they have, we use them, but they have fallen out of preference in the treatment of patients with Waldenstrom's, at least earlier on in the disease process. Alkylating agents are used much more commonly, specifically cyclophosphamide and bendamustine. And as you can see in that graph, the response rates are very high, anywhere between 70 and 90%, with progression-free survivals measured in the several years. Now, into more details, bendamustine has been compared in a clinical trial against rituximab and CHOP being a 4-agent chemotherapy regimen. And even though the study was relatively small with 20 patients on each arm, it gives us a good idea that bendamustine and rituximab is a very effective regimen with a high response rate and a very durable progression-free survival, approximately 5 to 6 years. And it seemed to be a longer progression-free survival than the patients who actually got R-CHOP. Now, we talked about potential side effects, and bendamustine does have some side effects, specifically cytopenias, and the very tiny risk of about 1% of developing a secondary myeloid leukemia that could potentially be hard to treat. The other agent that we use very often is cyclophosphamide, and we typically use it in combination with rituximab and dexamethasone. It is very well tolerated as well. maybe some blood count dropping, maybe some gastrointestinal side effects such as nausea and vomiting, but otherwise very highly effective as well, and a progression-free survival that is measured in the several years. Besides chemotherapy, we do have another group of agents that belong to the family of proteasome inhibitors. Proteasome inhibitors are non-chemotherapy agents that we have taken essentially from myeloma, and have shown to be very effective. There are 3 proteasome inhibitors currently available in the market in the United States, and that includes Bortezomib, Carfilzomib, and bxazomib. And we do have clinical data supporting the efficacy and safety of these agents in patients with Waldenstrom's. In this table, I'm summarizing the experience that we have with these agents and these combinations. And again, an overall response rate very well between the 80 and 90% rate, and major response rates between 70 and 80%, and progression-free survivals in the several years as well. Bortezomib-based therapies have been around the longest. Bortezomib has been around for over a decade currently. And when we combine this agent with dexamethasone and rituximab, we have a high efficacy rate. A very fast response as well. Usually within 4-8 weeks, we are seeing a response. And one of the good things about these type of treatments is they do not associate with an increased risk of secondary cancers. They do have, however, some specific side effects, and specifically Bortezomib has the side effect of neuropathy. When it's given intravenously twice a week, the neuropathy rate seems to be higher, but more recently we have been using subcutaneous formulations once weekly, and with that, the risk of neuropathy has decreased dramatically. With these agents, we always have to be aware that there is a risk of reactivating herpes zoster, and patients can develop shingles. So patients need to be on the medication as a prophylaxis for shingles throughout the treatment. The other agent that we use often is Carfilzomib. Again, highly effective, very little neuropathy with Carfilzomib. And interestingly enough, one patient attained a complete response and actually became MYD88 negative. The patient was positive at the beginning and became MYD88 negative at the end of treatment, showing that it's a very deep responses can be obtained with Carfilzomib as well. It does have other potential side effects different than Bortezomib, in which it can cause some cardiac issues, specifically in elderly patients. It can be associated with an increase in glucose and cholesterol, and decrease in your IgG levels that increases the risk of infections. The risk of shingles is also present with Carfilzomib, and patients need to be in prophylaxis for that. And the most recent available proteasome inhibitor is bxazomib, which is oral. Bortezomib is given subcutaneously, Carfilzomib is given intravenously. Bxazomib is given orally. It's a pill that is taken once a week. And this is a study that we just were working on in terms of publishing the long-term data from this study. And we can see that the time to response is about 2 months. But having CXR4 mutation seems to delay the onset of that response to about 4 months instead of 2. The depth of the response was very high as well. We have over a 90% efficacy rate for the combination of bxazomib. But the depth of the response in terms of VGPR, which is a very good responses, was about 36% in patients without CXR4 mutations, and probably about 7% in patients with CXR4 mutations. So the time to response and the depth of the response seem to be impacted by CXR4 mutations. But when we look at the progression-free survival, the progression-free survival is approximately 4 years with this agent, with this regimen. And there was not really a difference in progression-free survival between patients with and without CXR4 mutations. The side effect profile of bxazomib was very benign. We had no severe side effects to speak of. One patient had neuropathy, and this is a patient who had a pre-existing diabetes. There was some infection risk, which happens with all the other treatments, but we didn't see any other signs of concern in terms of cardiac issues or neuropathy or severe neuropathy. So any of these 3 agents can be used in patients with Waldenstrom's in the front line, as well as the relapse setting. And more experience will come, as time goes by. Now, how do we know which approach is better? Is it chemotherapy or is it proteasome inhibitors? So we did a retrospective study because I don't think there will ever be a prospective study evaluating this specific question. So we accumulated data from patients who got treated with cyclophosphamide and bendamustine and bortezomib, And we looked at their progression-free survival and their overall survival. As you can see, the curve there, really no major differences between these three agents. If we want to be purist, maybe there's some benefit of using Bendamustine or Bortezomib over cyclophosphamide, just barely in terms of progression-free survival and overall survival, but overall, very reasonable treatment options. Now, after we treat patients with these agents, usually in combination with rituximab, we have been considering the use of maintenance rituximab. And a number of retrospective studies, including ours and from some other institutions, have shown that the use of maintenance rituximab after induction compared to observation after induction has shown to have benefits in terms of progression-free survival as well as overall survival. And for that reason, we have been recommending in some patients maintenance rituximab given every 3 months for a couple of years to try to deepen response and prolong progression-free survival. However, more recently, at least last year, at the American Society of Hematology meeting, the Germans presented finally their analysis from the MAINTAIN study, which is a randomized study. Patients, about 200 patients got bendamustine and rituximab, and only if they had a partial response or better, so minor responses are not included in this analysis, only partial response or better, then these patients were divided in two groups. Half of the patients got maintenance rituximab and half of the patients did not get maintenance rituximab, just get observation. And as you can see here, the progression-free survival and the overall survival curves practically overlapped, suggesting that really there was no additional benefit in terms of any type of survival with the maintenance rituximab for 2 years. Obviously, patients with minor response were not included, so that that doesn't apply to those patients specifically. But if one wants to look a little bit deeper into this, there appeared there was some benefit in patients who were older than 65. They benefit more than patients who were younger, for example. And patients who had a higher risk in terms of the IPSS-WM, the scoring system for Waldenstrom's, it seemed to be that the higher risk patients tend to have benefit from maintenance. So we need to have a better understanding of, there must be a group of patients who might benefit from maintenance, and we will know more when all the data is available for evaluation. So moving away from these rituximab-based combinations, I think the advances in the genomic understanding of the disease has really led towards development of newer treatment options. And one of the big, I would say, landmarks on the care of patients with Waldenstrom's is the understanding of the MYD88 mutations and its prevalence. So this was a study that came from Dr. Trion's lab, from our laboratory or research center, and has been validated, as you can see in this graph, multiple countries in different parts of the world. And it shows that over 90% of patients with Waldenstrom's have these mutations in MYD88. Now, a second mutation that seemed to be important is some mutations in CXCR4. Again, this is a study, a group of mutations that were identified at the Bing Center and reported about 5 years ago now, and has been then validated in other groups, in other studies as well, showing that about 20 to 30% of patients do have mutations in CXCR4. Now, what is that importance? We believe it is important because it helps us understand the biology of the disease and maybe develop treatments that are biologically driven. And specifically in this graph, I'm not trying to confuse you with this graph, but I'm trying to show you that MYD88 signaling and CXCR4 signaling, they kind of supplement each other. They complement each other, and that's an important aspect of the biology of the disease, because if we were to aim at attacking MYD88 signaling, we always have to have in mind that in those patients with CXCR4 mutations, there is an additional activation pathway that we also need to have in mind. So Dr. Trion's laboratory work showed that BTK was a very important component of the activation pathway for the MYD88 mutated cells, and that gave way to a molecularly targeted agent inhibiting BTK to enter clinical trials in patients with Waldenstrom's. So BTK inhibitors then have become, I would say, a very important treatment option for patients with Waldenstrom's. The first BTK inhibitor to hit the market was ibrutinib, And we can see here ibrutinib as a single agent. This is without the addition of rituximab. We can see how in these 3 studies, we have an overall response rate between 90 and 100%, major responses in between 70 and 80%, and progression-free survivals measured in several years as well. So highly competitive with the rituximab-containing agents that we have reviewed previously. Now, this is where the genomic profiling of patients comes into play, specifically for BTK inhibitors. We see here that in the initial study on ibrutinib, on 63 patients that were previously treated, received ibrutinib, 36 patients had the MYD88 mutation only, 21 patients had the MYD88 and the CXCR4 mutation, and only 5 patients had no MYD88 and no CXCR4 mutations. And when we separate the patients on those 3 groups of patients, we see that the patients that benefit the most from ibrutinib therapy are the patients without CXCR4 mutations, but with MYD88 mutations. We have a response rate of 100%, major response rates of 97%, and a VGPR well over 40%. Those numbers are much, very, very competitive, I would say, compared to any other regimen that we have seen previously. In patients with CXCR4 mutations, the overall response rate was 86%, with a major response rate close to 70%, and a very good response rate of about 10%. So a little bit less effective in that group of patients, but effective nonetheless. It was much, much less effective in patients without MYD88 mutations. And in that population, at least in our clinic, we tend not to recommend the use of ibrutinib, at least not earlier on. In the long-term study, we have seen that the mutation profile also affects the progression-free survival on ibrutinib. And as you can see in the graph on the right, the curve at 75% at 5 years, which is a very, very nice outcome. Those are the patients on ibrutinib who were MYD88 only mutated. Patients with MYD88 and CXCR4 is the dashed red line, in which a median progression-free survival is about 4 years, and much shorter, a median of about 24 months in patients without MYD88 or CXCR4 mutations. A similar finding was reported in the study in which we gave ibrutinib to about 30 patients who were previously untreated. So this is first-line ibrutinib. The response rate was about 100%, a major response rate between about 80%. But when we look at the CXCR4 mutated patients, the major response rate were about 70% versus 90% in patients without CXCR4 mutations, and the very good response was 7% versus 30%. The time to response also seemed to be affected by CXCR4 mutations. Specifically, attaining a response took about a month. With ibrutinib, it took about 2 months for the CXCR4 mutated patients. And the time to a major response took 2 months in patients without CXCR4 mutations and about 7 months in patients with CXCR4 mutations. So the depth of the response on these patients, as well as the time to response, seems to be affected by the presence of CXCR4 mutations. So along came the phase 3 study comparing ibrutinib plus rituximab versus rituximab and placebo. And again, this combination of ibrutinib and rituximab showed to have a higher depth of response, a faster onset of response, and also a much higher progression-free survival in patients who get the combination versus patients who get rituximab alone. And that's an important finding because that gives us an understanding that adding ibrutinib to rituximab improves rituximab. However, it does not precisely answer the question if adding rituximab to ibrutinib improves ibrutinib. And as otherwise, there would have been a third arm in that study of ibrutinib alone, or ibrutinib plus placebo, which obviously was not part of that. So we don't have an answer to that question alone. And I don't think a clinical trial is going to be designed to actually prove or disprove that. So what I have done is I put a table here in which I'm putting the data on ibrutinib rituximab versus ibrutinib alone. This is not statistical comparisons, just crude data put in a table. And you can see there that the outcomes in terms of response rates and major response rates and very good response rates and even progression-free survivals do not seem to be too different between the combination of ibrutinib and rituximab versus the data already known on ibrutinib alone. So here comes the issue in terms of should we use ibrutinib in combination with rituximab or alone, and how do we do this? And this is a matter of ongoing debate. And as there's no data, there's only opinions. Now, ibrutinib also has specific side effects, and the one that I think concerns oncologists the most is these arrhythmias, these irregular heartbeats. And the reason we are worried about this is because we're not cardiologists, right? So how do we manage this? I mean, however, as we have seen more patients and have become more accustomed to seeing patients developing atrial fibrillation, then I think our management has also, we have become less concerned about that, and we have been able to manage these patients more appropriately. So a patient comes to my clinic, the patient has an irregular heartbeat. Most of these patients are not dramatically symptomatic from it. So I do an EKG, I identify the AFib, the atrial fibrillation, and if that is the case, there is a scoring that I can calculate. There's an app for that. A score that I can calculate in terms of the risk of a stroke that patients can have with AFib, which is the main concern in patients with AFib. So if the risk is very small, the patients do not need any anticoagulation. If the risk is higher, then patients need to be on anticoagulation. And at that time, I myself start the patients on medications to control the heart rate. I give medications, blood thinners, and then I arrange for a cardiology follow-up, because I think a cardiologist need to be involved in this within the next following week or two, and then the patient decides what to do next. Obviously, that the decision is twofold. I mean, we can either continue ibrutinib and then deal with the AFib, or we can stop ibrutinib and switch to a different type of treatment. Now, most of the patients who develop these side effects are already in a very nice response. So a number of our patients have decided to continue ibrutinib and treat the AFib along the way, and we have been able to manage that without too many problems. So I don't think arrhythmia or AFib is per se a reason to stop ibrutinib in all patients. And again, it's all about the comfort of the patient and the physician taking care of the patient in terms of managing that complication. So just to summarize, these are the NCCN, or the National Comprehensive Cancer Network guidelines in terms of therapies. A new version should be coming up very shortly. And as you can see here, this is the frontline treatment of patients. Their preferred regimens tend to be bendamustine, bortezomib, cyclophosphamide, and ibrutinib with and without rituximab. There are other treatment options on the right hand that some of them we have talked about as well. Carfilzomib, ibrutinib, bxazomib is there, and other regimens as well. And it's a very similar treatment approach for patients in the relapse setting. Bendamustine, bortezomib, cyclophosphamide, and ibrutinib remains preferred regimens, and there are other regimens that can also be used on those patients, upon relapse. Now, at Dana-Farber, we have a very specific approach, and again, it's because we can do this. I'm not saying that everybody should do this, but we can do it because we have the research capabilities and the funding to potentially to run these studies. So we do genotyping for MYD88 and CXCR4 in all our patients who have a bone marrow biopsy done with us. We do have genotyping on those patients. And then we separate patients on those three groups that we were talking about earlier: patients with MYD88-only disease, patients with MYD88 and CXCR4 mutations, and patients without MYD88 or CXCR4. So in patients who have only MYD88, we do prefer BTK inhibitors alone in that group of patients. And the reason is the response is fast, the response is deep, the response is long-lasting. And I think the numbers that we have seen in terms of progression-free survival, which is the durability of the response in patients with MYD88-only disease with BTK inhibitors, is actually somewhat superior to what we have seen in other regimens. If the patient does not have MYD88 or CXCR4, so all the way on the right, those patients, we believe, do not benefit from ibrutinib, and these patients should potentially be treated with bendamustine or bortezomib or cyclophosphamide in that setting. Now, if a patient has CXCR4 mutations, then we actually separate these patients in two different groups. In the patients in whom a rapid response is required, meaning patients having a high degree of IgM, very anemic, having hyperviscosity, or the patients who do not need to have a rapid response, patients who are a little bit anemic, mildly symptomatic, or moderately symptomatic. That is a very subjective approach, but it's an approach that we are following at Dana-Farber at this time. So if the patient needs a rapid response, then those patients need to be plasmapheresed and potentially consider, other treatments that are not BTK inhibitor-based, chemotherapy or Bortezomib-based regimens. If the patient does not need a rapid response, we can consider BTK inhibitors. And if we don't see the response that we want in a specific time frame, we could consider adding rituximab in those patients. And that's the way we use the ibrutinib-rituximab combination. But again, this is our very specific approach, and other institutions can have other approaches. I want to be very clear about that. So interestingly enough, there's a new BTK inhibitor coming in the markets, acalabrutinib. Acalabrutinib is already approved for the management of chronic lymphocytic leukemia, or CLL. This is a study in patients with Waldenstrom's, got published, I think, earlier this year. It's a multi-center European and American study. And about 100 and some patients with Waldenstrom's got exposed to acalabrutinib, which is taken 100 milligrams twice a day, 1 pill in the morning, 1 pill in the afternoon. And you can see here the response rates were very high, about 90%, with major response rate about 80%. And when we look at the progression-free survival, at least at 2 years, anywhere between 80 and 90%. The side effect profile, I would say, is relatively similar to ibrutinib. The company is claiming maybe lower rate of AFib. In this study was around 5% compared to the AFib in Waldenstrom, which is around 10%. But again, there were no direct comparisons, so it's hard to make any clear statements in that setting. But we do have seen similar side effects than ibrutinib in terms of bleeding and AFib and infections, as well as decreased blood counts. But again, a treatment option that is of interest, specifically in CLL, there was a study in which patients were on ibrutinib and they were having a toxic event from ibrutinib, and they switched from ibrutinib into acalabrutinib. And most of the patients maintained the response, and the side effect profile was a little bit more benign. And again, there's no study like that in Waldenstrom's, but that's an interesting aspect to evaluate. And I think acalabrutinib will probably become or will be added to the treatment options for patients with Waldenstrom's probably later this year. So just to summarize current treatment options, we can see here that we have chemotherapy-based regimens, and we have proteasome inhibitor-based regimens, BTK inhibitors now, and obviously the monoclonal antibodies that we use seldom, just because antibodies alone do have a lower rate of response, and they tend to be a more delayed onset of response as well, and obviously the duration of responses are a bit shorter. So we favor combination therapies or BTK inhibitors on patients with Waldenstrom's. But there's a group of patients who might benefit from only monoclonal antibodies, specifically elderly patients who are not a candidate for any other treatments or things of that nature. So multiple treatment options, and I bet you that if I give this lecture in a week, in a year or two, these treatment options are going to be this list is going to be much larger, and that is actually a good thing. So to finalize, I want to just review with you some of the recommendations by the American Society of Hematology in terms of treatment of patients with indolent lymphomas in the context of the COVID-19 pandemic. Now, these are not recommendations specifically for Waldenstrom's. We have created a document for Waldenstrom's, which we have submitted for publication, and once that becomes public, I'll be happy to share that with you. But we have used the backbone of the American Society of Hematology recommendations to create our Waldenstrom recommendations. So many of our recommendations are going to match these ones. I want to present to you 8 recommendations that basically summarizes the most important aspects of the care of indolent lymphoma patients in the context of the COVID-19 situation. Number 1, let's talk about treatment indications. Observation remains a preferred, option, specifically in patients who are asymptomatic or even minimally symptomatic. So our threshold to initiate treatments on patients should be a little higher, and not initiate treatments just without a clear reason or a clear symptom that is affecting the patient's activities of the daily living or quality of life. Now, once the decision on treating becomes into place, and we need to treat somebody, we need to decide between a single agent or a combination. Single agents tend to be preferred over combination regimens, just because combination regimens typically have a higher risk of infections compared to single agent combinations. We need to balance this out with the efficacy that we're looking for as well. So none of these are, black and white type of approaches. These are just suggestions and preferences by the Society of Hematology. When thinking about oral versus parenteral means something that is not oral, either intravenous, subcutaneous, and things like that. So Recommendations by ASH are oral agents are preferred, specifically BTK inhibitors and BCL2 inhibitors like venetoclax, even though it's not available for Waldenstrom's yet, probably will be a little bit later this year. So BTK inhibitors and BCL2 inhibitors, being oral agents, minimizes visits to the clinic. It minimizes the risk of infections associated with chemotherapy and rituximab. So they tend to be a little bit more preferred than intravenous or subcutaneous treatments at this time. Now, if the patient is already on chemotherapy, then reduce the number of cycles, right? If we get into a nice deep response with 4 cycles of chemotherapy, maybe we don't need to give cycle 5 and 6, right? So for example, now obviously that needs to be balanced between what we need to obtain and how the patient is doing with the treatments. The recommendation by ASH is to avoid maintenance rituximab. And again, it all depends, right? If the goal is to bring the IgM down and patients are already in a nice IgM, asymptomatic without anemia, I would say, it's reasonable to stop. But if somebody is concerned about some end organ damage, for example, or neuropathy, that maybe we need to consider a little bit different aspects on these patients. And avoid transplants. I think in general terms, transplants should be, delayed. There's no curative approaches on transplants. And then that's just my opinion in that sense. There is a formulation of rituximab that is subcutaneous, and actually the infusion is about 5 minutes. So ASH is recommending subcutaneous rituximab over intravenous rituximab, and that would be great. It's just that subcutaneous rituximab is not approved for Waldenstrom's. It is approved for follicular lymphoma, in diffuse large B-cell lymphoma, and I have had some trouble getting subcutaneous rituximab approved for patients with Waldenstrom's. I know that other patients in other centers have been able to get it. And if that is a possibility, then it should be pursued. Now, I am in coordinations with the National Comprehensive Cancer Network to include, even though there's no specific data, we can transpolate the data on follicular lymphoma into Waldenstrom's. And we are very likely going to include subcutaneous rituximab later this year for the management of patients with Waldenstrom's. There's a study that just came out from the Netherlands in which, subcutaneous rituximab was used in patients with Waldenstrom's with great effect and great tolerability. So that is something to look forward in the future. Very few words on clinic visits. The recommendation still is to minimize in-person clinic visits if possible, and remote visits are preferred. Telehealth, telemedicine, either video or phone. I think these are easier in patients who are on oral agents or patients who are being monitored or in a watchful waiting approach. In patients who actually need to be infused or injected, it's a little more difficult, and I think those patients probably need to be seen in clinic. Supportive therapy, I think we need to be very proactive with the use of supporting agents like medications to boost white blood cells or medications to boost hemoglobin levels. Very proactive in terms of antiviral and antibacterial prophylaxis, and even the use of intravenous immunoglobulin, and minimize transfusions. Minimize transfusions is specifically directed at providing transfusions to the people who actually need them. So if somebody has, so essentially not transfused just based on numbers, but rather based on symptoms. In radiotherapy, we use very seldom radiotherapy in patients with Waldenstrom's, but the recommendation is to reserve radiotherapy specifically for urgent situations, meaning if there's a compression of the airway or compression of the spinal cord, then those are situations in which we should consider radiotherapy. And with that, I really would like to thank you for your attention. This is a summary of the current treatment options for patients with Waldenstrom's. And as always, it's a pleasure, being here talking to you. Thank you.